Hello, everyone on our call today. Welcome to the May meeting of HealthInfoNet's Behavioral Health Information Technology Reimbursement Initiative. Thanks for joining us. I'm Gemma. I think you all know who I am at this point. I am the Behavioral Health Program Coordinator at HealthInfoNet and the chairperson for today's call. Before we get started, just a reminder of some housekeeping duties that we do here. And I think a lot of you were on the call when I was going through the *7 unmute, *6 mute. But we do have everyone on the call muted. So if you do need to speak, it is a *7 to unmute and a *6 to mute. You can also ask questions through our chat box on the lower left for those of you who are new to the call. I know we have a lot of new people on as well. And we will have questions at the end of the webinar, so you can also wait until then and you can either chat with us at that point via chat or submit questions over the phone by doing *7 to unmute you. So today we're going to begin with a brief update of our work together, and then we're going to move to the really exciting part, and that's when we feature some of your colleagues, our hardworking BHOs, and the groundbreaking work that all of you are doing. You know, HealthInfoNet is one of the most forward HIEs in the country. We actually consider ourselves the best, but and we're not biased by any means. But the reality is, and it's one of the things that we're so excited about working with all of you, is that not even the best appliance that you have in the kitchen or the tool that you have in the toolbox works if it just sits in the box unused or sits on the counter unused. And what we're seeing at HealthInfoNet with the work that all of you are doing is how when you use HealthInfoNet, that the care is transformed. And that when intelligent caring providers like you and the people that will be talking with us today on this webinar telling us how they use the tool, when people like all of you use this tool, you make it a great tool. You guys are actually using HealthInfoNet in ways that have not been used before, and you are applying your skill set, your specific special skill set to the data that's in HealthInfoNet, and when you're doing that, you are actually making such an incredible difference to the healthcare outcomes of your clients and to the quality of their lives. So today we have Jason White from MBHO, we have Ariana McIntyre from Wings, and Abby Spadone and Caroline Schnell from Catholic Charities joining us. And finally, for today's webinar, Katie Senze will talk with us about what happens after the SIM grant is over. So the first thing that we're going to do is to look at the quality project and milestone updates. Now, all of our organizations are currently viewing HealthInfoNet, and we are happy to report that on this list that you see today, that we actually have more organizations on this list than we had the last time we showed this list to you. So that's a good thing. The remainder of the behavioral health organizations that are not on this list are working really hard with Rob Cook, my hardworking colleague at HealthInfoNet, and their IT teams and EHR vendors to join this list. So thank you everyone for your hard work on this. We know that this is a heavy lift, and we really appreciate it. April is a heavy vacation month, and but even with that, with the vacations and IT glitches that sometimes happen at organizations, that brings down usage of the portal, we still found some heavy-hitting users and organizations. And so here's a call out right here on this slide to April's heavy users. And you know, I know I run you hard on this. I'm contacting you, saying how come you're not using it? How come the numbers went down? Or where can we increase usage? And one of the reasons that I do this is because we here at HealthInfoNet are seeing the difference, because of the stories you're telling us, of the difference that your usage of HealthInfoNet makes in the lives of your clients, and that it impacts the outcome for them, a lot of healthcare events that happen. And because we know this, that's why we're really emphatic about your staff using this tool. That's why I'm on you about this. So I really just want to take a moment to thank all of you for using HealthInfoNet to transform care, to do that heavy lifting of changing staff workflow. It's been hard. I know it's been hard, but it's been well won, what you've gotten out of it and what your clients are getting out of it. So I'm just thanking you. Thank you so much. So because you're doing such beautiful work, I want to be able to capture it. We all want to be able here at HealthInfoNet to capture the work that you're doing. So because of that, there's some new asks for you regarding your reporting for the quality project that you're giving me every month. So we do ask for the monthly number of notifications received and responded to by staff. Now, a lot of you give that number to me in the report. I'm asking for all of you to start doing that. It really helps me to be able to tally up the work that you're doing, what it looks like. The more specific that I get from you, the more specific I can be when we're reporting out to the state. So please, please give me everything that you can in terms of the numbers of notifications received and responded to. The next thing that I really want you to do is, and some of you do this and some of you don't, I would like all of you to also in the report to identify the specific interventions that your staff is using after they receive the notifications. Again, we really want to report out on what you're doing. We need the details of the numbers and the details of the actual interventions that you're using for us to be able to do that well. There's something, and I will send out to you a little form so you can get that back to me. This is not part of the quality report, but I would like to get from each of our organizations a one-time description on how your different staff roles are leveraging the clinical portal. All of you use it differently. So let us know how the nurses use it, how the case managers use it, how your prescribing doctors or your prescribing NPs use it, how the social workers use it, the psychologists use it, et cetera. Give us an idea of just specifically how they use it. And then another thing that is going to be really helpful for us just to keep tabs on is a calculation internally of how your interventions are reducing costs. And Jason's going to talk a little bit later after I have my little talk with you right now. Jason follows. And Jason will talk to you a little bit about what he's doing with duplicate labs. So these are some interesting things that we want to be able to share. We know the good work you're doing. Please help us let everyone else know too. So give us this information so that we can do that. So we continue to have questions that come in, and I like to share them because if one of you has a question, it's likely that others of you have the same question as well. So the first question is about sharing HealthInfoNet data with your clients. And so the question, can a client receive a copy of documentation that's in HealthInfoNet? And the answer is yes. Clients can have a copy of this documentation. They can have it even if it's behind the closed shielded area, the mental health area, the HIV area, because it's their data. That data is their data too. So yes, you can give them a copy of the documentation that's in HealthInfoNet, but only their data, not someone else's data. But I think that's pretty clear. The second question actually has two different answers because it's about two different forms. It's about getting the opt-in form and the opt-out form to HealthInfoNet within the legal time frame, especially when it comes in during the weekend. So you have an idea that it has to come in within 2 business days, and this person thought it was 24 hours. And it's good for us to review these things. There's so many rules and regulations, it's easy to mix them up. It's a 2 business day return. Let's go to the next slide because I just want to do this out according to what the law says. So the first part of the answer answers the opt-out form because there's 2 different laws about each form. So with the opt-out form, it is a law that we have to get it within 2 business days. But if it comes in on a Saturday, you don't have to fax it the Monday. You fax it no longer than Wednesday. It's 2 business days after signing, so that would be the Monday, Tuesday, Wednesday. You get that to us. The second answer is about the Optin Form, which is different. There's actually no state law on when we receive the Optin Form, just to be clear. The state law does require that a staff member witnesses the signature. Another option that the client has is they can have their signature witnessed by a notary. So those are some clarifications. I think it's important when you have questions to let me know, and I will continue to use this platform to share it with everyone on the webinar, and whoever sends me that question, I will get back to you as soon as possible with the answer. And so now I want to hand this over to Jason White. He's the CEO at MBHO. I just found out this morning that Jason is a doctoral candidate at UNE, and that his research will be published in August, it is. I'm going to quote Jason here. He said, "If I had to do it over again, I would have studied behavioral health using HealthInfoNet because it has been a lot of work, interesting, and fun." Well, Jason, I think you should do that research project anyway, but that's just me. We can give you a doctorate from HealthInfoNet. I'm not sure if that would please you, but I'll give you a certificate. You can put it on your wall. Well, Jason, it's been a lot of work for you. You've been tireless. And
all right. Thank you, Gemma. Good afternoon, everyone. So the question is, how did we increase our HealthInfoNet usage? Initially, I had completed 2 trainings on the use of HealthInfoNet with all of the organization's clinicians. After using the audit tools, I noticed that they were still not accessing it or accessing it very little. There could be several reasons why they were not accessing it. Maybe fear of accidentally accessing somebody's records. Many of us that have gone to school know that we do not access client records unless we have permission or a release. And HealthInfoNet access and processes is different than what many of us have learned in school. After a few months of reviewing the audit report and working through the supervisory chain, I realized that I had to take a more assertive approach. I mandated that anyone that has access to HealthInfoNet review their clients before client meetings and report to me daily on their usage. What I found was that clinicians and anyone that has access either reported to me daily or at least every couple of days and were better informed on what was going on with their clients. The next few slides will show how HealthInfoNet helped make our services better. Next slide, please.
Okay, and Jason, before we go on to the next slide, I just want to underline how impressive you are. Actually, I underestimated you. I said that you doubled usage in less than 1 month. I will just go through your numbers. In February, you had 1 user and 20 lookups. In March, you had 6 users and 193 lookups. And in April, you had the same 6 users and 237 lookups. So all that work that you just detailed for everyone really had an impact.
Yes, and it has really affected the services they delivered. So it's really good. I will say that access to HealthInfoNet has a far-reaching effect on the delivery of the behavioral health services, much larger than what we initially expected. Notifications alert in real time, informing us of when someone goes into the ER. On a few occasions, when I contacted the case managers, they were either aware or were with the client at some point during the day, which was great. Case managers will often contact me or someone that has access to HealthInfoNet to find out why their client went to the ER. And sometimes we look in HealthInfoNet when we're having difficulty locating someone, when they may have been admitted to the ER instead. In our organization, HealthInfoNet Access has been used to obtain ER information, consult information, lab information, pregnancy test results, medical appointments, and histories, some histories going all the way back to the 1990s. It has really been effective in obtaining information on complete client situations. Let me give an example of how we used it, or how we use it. One of the hospitals wrote in a discharge summary that an individual was discharged into our care, which was not accurate. The client was discharged to a shelter without our involvement. We called a meeting with the hospital and asked why this person, who could only walk a few feet, was discharged. We also noted that the hospital staff had scheduled the client for a follow-up, the following week that was over 80 miles away from the shelter. And I don't think that they were aware or that the moving parts of the organization were aware that this appointment was scheduled until we had this meeting. Meanwhile, this client was making the rounds to other hospitals. We informed the hospital that this client's issues were going to continue as evidenced in HealthInfoNet, and unless we did something different to stabilize this person, this client would continue to come to their hospital. Next slide, please. We have also noted, especially with prescription refills that are noted in HealthInfoNet, that clients sometimes only refill certain medications and not others, usually refilling more controversial medications such as methylphenidate. It has also alerted us to those who struggle with addiction. During one of our behavioral health home meetings, we uncovered that someone was recently discharged from our med clinic where the plan was to prescribe benzodiazepines to discontinue them. And the client was still receiving the same dose that was scheduled to be discontinued with their new provider. Certainly, we would not say to the client that we were in HealthInfoNet and saw that they were doctor shopping, but at least now we can look at the other components of treatment to include why the client is having the types of issues that they're having. Next slide, please. One of our clinicians noted that she has some older clients that have difficulty understanding their PCP's direction, or that they do not understand why they have so many tests and labs. The clinician was able to help the particular client to understand how each component of medical care informed the medical treatment, which in turn lowered his anxiety. Next slide, please. The same clinician stated that she had a client that had severe memory loss due to a car accident. This client had great difficulty articulating the events that took place and that informed his care. It was hard for the clinician to put the entire story together around the accident during sessions. Information in HealthInfoNet not only helped to inform the clinician of the actual story, but allowed her to help him clarify and understand what actually took place. Next slide, please. HealthInfoNet usage has also helped us to prevent duplicating services, such as lab orders. We have recently started tracking lab orders and viewing HealthInfoNet for labs, and I'm talking labs in regards to medication management. Initially, when we started tracking this, we found the average amount of labs being used from HealthInfoNet were about 6 over a 2-week period. Now we are finding, with our single prescriber, that as many as 5 lab orders in a single day were replaced by pulling them from HealthInfoNet. I don't know exactly what the cost is on that, but I would imagine that's a phenomenal savings. These lab orders that were pulled were current from recent hospital visits by the client. Next slide, please. Our motto is providing the right treatment the first time, and HealthInfoNet brings us closer to making that a more accurate statement. This inevitably targets access, quality, and cost. An example might be that when we look at the patient summary in HealthInfoNet and see that someone is going to the ER every 2 months on average, we might review that and say, why aren't we setting this person up with a PCP appointment every 2 months instead? HealthInfoNet is even more powerful when used in conjunction with the behavioral health home model. In our BHH meetings, we review the claims data and then view the HealthInfoNet records. The claims data tells us who our highest users are, as well as users with the highest cost, which helps us to prioritize who to discuss in these meetings. That's all I have, unless anybody has any questions.
Well, thanks, Jason. Actually, I want to ask you a question about your staff, because you really have transformed their workflow here, and they now have access to HealthInfoNet because of your real top-down management style, asking them to do it, really asking them to be accountable for their usage of HealthInfoNet. What has been their reactions now that they've gone in, now that they have been able to access HealthInfoNet? They may have initially been resistant. What are some of the feedback that you're getting now?
The feedback that I have gotten is very good. I mean, the clinicians in particular are happy to have this additional information. What it does is it provides enough information to inform the diagnosis a little better. You know, sometimes we might think that a client should be diagnosed with bipolar, for example, when instead what they're really having is problems with a thalamus or something like that, or issues with the brain. So that's very helpful, and I think that the medical issues that we're able to see do inform the diagnosis, because some of those issues that they're having cause significant distress. In the med clinic, we learned some things by going through the files, for example, and I brought it up earlier, pregnancy testing. I know that our prescriber is always looking for that sort of information, but the client isn't always forthcoming with that. And if they've had a couple pregnancy tests in a row, at least we know that they're thinking about getting pregnant, but they're not actually disclosing that to us. So that could have quite a detrimental effect on, both the client and the baby. During our BHH meetings, we sit down and we go through all of the claims data in conjunction with HealthInfoNet. We pull HealthInfoNet up on the screen and view it in real time, and we can see when the prescriptions are being refilled, what's going on. We can see the consults, the ER visits, and we can see the appointments that have been scheduled for that client. And our prescriber said that this is probably one of the best grand rounds, per se, that he's ever attended, and that he's able to walk away with an understanding of the full treatment of that one individual and how his work relates to providing treatment to that client.
Well, thank you, Jason. You certainly just illustrated, while you were talking, you had your motto up there, and that's exactly what it's helping you to do, to provide the right treatment at the first time. Thank you so much, and people stay on. Jason can take questions that any of you might have at the end of the webinar. Thank you, Jason.
Certainly, you're welcome.
Okay, so now I want to introduce you to actually bring in a new voice. We actually haven't had a case manager speak on one of our webinars before. So it's about time. And Ariana McIntyre joins us from Wings today. Ariana is a heavy user of HealthInfoNet. And so when I was looking at her numbers, I thought, I have to call her up and find out how she uses it. And one of the first things that she told me is that, I think quotes, all these quotes are hers. We get more information from HealthInfoNet than we get from parents, and I don't doubt that. But I also love this image that she gave me, that all of the case managers at Wings sit around the table and they brainstorm how to use it. And I think that that's an interesting thing, because as we listen to Ariana talk about how she uses HealthInfoNet, you can see that maybe some brainstorming around the table really is a good thing. So with that, I want to ask you, Ariana, to tell us a little bit about the information that you like to access on HealthInfoNet.
Okay. Well, so I like to go into HealthInfoNet just to kind of check medications, because I do a lot of med management visits with kiddos, and I like to just confirm that parents have filled those medications. And then I like to get the timeline as to, are they filling them up as prescribed? Because it gives you the 120 days of prescriptions that have been, and then who prescribed them. Sometimes it'll give you the detail of how to dose the medication. Sometimes when you're in a meeting, you just don't get all of that information, so you can kind of use HealthInfoNet, go in and get your missing pieces.
And then what do you do with that information? You take that information and you work with the doctor, you talk to the family, what do you do?
Yep, I'd use it with the family, kind of just to check in and make sure that they filled the medication, if they have any questions on the medication, are they seeing a change in behaviors, prep for questions for the next med management visit. Do we need to coordinate with a PCP in regards to the medication? If they have any concerns, just kind of following up with them, and then I can be like the middle person between the mental health provider and the PCP and saying, okay, the family has this question. What do you think we should do about it?
Great, thank you. And then you also mentioned that you have a yearly assessment, and you go into HealthInfoNet to kind of make sure you have the information you need to do that.
Yeah, with PCP visits, they do a lot of their notes, and sometimes they'll give a little blurb on patient history. And again, we don't get all the information from families because they've stated it so many times to so many people that they forget to tell you everything. So sometimes it's nice to go into HealthInfoNet, see the little patient history, and then you can bring it up like, oh, I was reading that this happened, 2 years ago. Do you want to explain more?
Yeah, and as you're talking, I'm reminded also of something else that you said, is that HealthInfoNet, because you talk a lot with the families about what you're seeing in HealthInfoNet, and that they're impressed with you for knowing so much. It makes you look good.
Right.
That's never a bad thing.
No, and then sometimes they're like, oh, I told you that?
Now, I know that there's on this particular slide we're looking at right now, these are some of the things that you look at in HealthInfoNet that you were telling me. What you do, and I don't even know that you're aware of it because it's so automatic for you to do this, but you ask questions. You're looking at the information, and you're always looking for how the data that's there in HealthInfoNet can best serve your client, where it helps you to fill in the gaps. So why don't you walk us through what you're looking for when you mine through the data that we have listed here. We'll start with the demographics.
So when you first log into HealthInfoNet, it pops up the patient summary or the patient snapshot, and it always gives like their address. And then I just try to confirm, is that their correct address? Does it have any missing information? Who's their emergency contact? I think that's all right in there as well. Just making sure that it's accurate to what I have based on, because sometimes they forget to tell their primary care, like, oh yeah, I've moved, my address has changed by, 2 streets over.
Yeah, and then when you look at the patient summary, you tend to be asking, what's new here? What have I missed, or what is somebody else missing?
Yeah, and that goes in line with like the current meds or the allergies, because you can see those, what medications have they filled in the last 120 days. It also lets you know if there's been any changes in allergies. That's up in the right-hand corner, I believe. I found out a kiddo was allergic to penicillin and then shellfish. So it's like, oh, pop those into my comprehensive assessment so that I know for future references, or in case it gets transferred to another case manager, they can pull my notes, or they can come into HealthInfoNet and say, oh, the previous case manager may have missed this. What can I fill in the blanks on?
Yeah, it's wonderful. And then you also are interested in the last well-child visit, and you look into HealthInfoNet to find information like that.
Yep, and then, if I notice that there hasn't been a visit, then coordinate with the family. Do we need to schedule the next one? Do you have any concerns? Do you need a new PCP? Go from there.
It really helps you to be proactive with the family.
Yeah.
Yeah. So, and you also are looking at the PCP notes and the special notes that are in there.
Yeah, in the PCP notes, sometimes it can be hard to read, but you just kind of scroll through and skim it, and it'll say, a summary, and then it'll, like who was at the visit. Sometimes they'll include case manager attended with parent and client. It'll also go into what referrals did the primary care make. We discussed occupational therapy, physical therapy, speech therapy, things like that. And then has that primary care made that referral? So I go in to check just to make sure, yep, we did discuss it. Okay, they've made that referral. Or do I need to call and check with somebody and say, hey, I was with this family. We discussed making this occupational therapy referral. Can we just follow up on that?
It's just such true coordination of care that you do, and advocacy for the clients and their families as well. It's a beautiful use of HealthInfoNet. I was very struck by the story that you had about one of the little girls in your care who who needed an MRI, because even though your clients are young, they can still have serious medical issues. So can you tell us that story? I think that would be interesting to those on the call.
Yeah, of course. So I have a kiddo who we've done multiple medical concerns. We've changed her medication with mental health providers in the last 2 years, and then kind of looking at, we've done a 24-hour EEG, a 48-hour EEG, and a sleep-deprived EEG, and we weren't seeing any concerns in regards to absent seizures. But it's still in the back of our mind that there's something that could potentially be medically wrong, and we want to make sure that we're not giving her the medication that could affect her. So then, we discussed it. I talked with my clinician, and I said, this kiddo has had all of these things, and we're still not finding anything, and we've sent them down to Portland. We've sent them to all these places just to see if there is something neurologically, and then they suggested, oh, well, can you do an MRI? And I didn't even think of it. So then went to the primary care doctor and coordinated and said, we've done all of these. Do you think there's anything else? Can we do an MRI or a CAT scan? And then it kind of just clicked with all of us, like, yeah, let's try this step as well to see if that will pull any more information.
And you are actually able to expand on this little girl's care by your curiosity, and you're asking, what can I do with the data? What's in here? What's missing? You ask the questions. You use HealthInfoNet in such an interesting way, Ariana. And I just want to close with this wonderful quote that you gave me. I love this analogy. It's just fitting to close with this, because I think everybody on the call would agree that your clients are fortunate to have you in their corner. You just do such an incredible job coordinating their care. Is there anything you want to just say in closing before we move on?
If anybody has any questions,
Yeah, you know what? They'll at the end they'll bring some in. But maybe, do you have any word of advice to your fellow case managers? What would be one thing you might say to them?
I always go in and check, and then sometimes if the information's not there, then that kind of prompts me to say, okay, who can I call to coordinate to see if I can get that information? Sometimes you can go in, kind of like with this slide, Wheel of Fortune. Sometimes the information's there. Sometimes it could take it a couple of hours with, ER notifications to put up that information. So just kind of always checking to see what's changed and what hasn't.
That's great. Thank you, Ariana. Just keep checking in and looking for what's new. I really appreciate you taking time with us today. Thanks.
Thank you.
And next we're going to hear from Abby Spadone and Caroline Schnell at Catholic Charities. Abby is the Behavioral Health Home Clinical Team Leader, and Caroline is Case Manager. We're so glad to have another Case Manager. We're making up for lost time here with both of you. I just want to start first with Abby. Abby she actually formulated a debriefing protocol for ED hospital admissions, and this is a wonderful tool that she's graciously offered to share, that we can share it with you, and I will be sending it out to you when I do my follow-ups and send you the recording of this webinar. So keep your eye out in your inbox for this protocol. And so today, Abby's going to share that with us. And with that, I'm going to hand it over to Abby.
Hi. I guess I should start with, I created this debriefing protocol because in the past I worked in a skilled nursing facility and really kind of noticed the importance of creating a solid discharge plan to prevent readmission after someone's been to the hospital. So that's kind of the background on where this came from. And the real purpose of this protocol is really to support a successful discharge for our clients, and again, to prevent any kind of readmission. What happens is when I get a HealthInfoNet notification of one of our quote-unquote high utilizers, when they've accessed the ED, I get that notification, I look them up, in HealthInfoNet, and then I forward that on to the care coordinator. And I usually try to copy and paste the summary, the information that was in the HealthInfoNet report, and I send that along to the case manager. That then triggers them to outreach the client and or the hospital if possible, and they go through this debriefing protocol, and it really just kind of allows them to take a closer look at the ED admission. So the first thing we really look at is what the presenting problem was, and we pull that straight from HealthInfoNet. It says that right in the document, coming from the attending doc, and what we like to do is compare that to the client's perspective of what their presenting problem is, because a lot of the time those do not add up. They're not often the same. Part of the reason we do this is to really get a sense of whether or not the presenting problem was appropriate for the emergency department, or was this something that the client could have maybe gone to their primary care doctor for, or urgent care. We had one client, when I got the notification, I looked him up, and his presenting problem was that he had a red, itchy eye, and he presented via ambulance to the emergency department for that. So that's something that, you know, when we start talking about this with the client, we can really talk about, well, was the emergency department appropriate? If it wasn't, where could he have gone instead, you know, and was there a barrier to him accessing another provider, for example, his primary care? The other reason we go over this with the client is really, again, to compare what the doctor or the emergency room provider views as the presenting problem versus what the client sees as the presenting problem. We had a client who, when I read her notification, it showed her presenting problem as being overly giddy and shaky. And when the care coordinator reviewed this with the client was kind of aghast, really, because she had gone in quite anxious because she had been having tremors for a few days, and she thought there was something really pretty seriously wrong. That really gave us insight into how those providers in the hospital maybe viewed that client, and how that could have really affected the treatment she received while in the emergency department. Next slide. So the other thing we like to talk with the clients about is, one, of course, how they got there. Did they walk? Did they get there via their own vehicle, with a friend? Was it an ambulance? It just really gives us a sense of how they're accessing the ED in general. We also like to dig a little bit deeper into understanding why the client accessed the ED, to really kind of parse out if it is something that's medical, or is there an underlying kind of emotional or psychological problem. We've had clients who will present with chest pain, and when the care coordinator really sits down and talks about, well, you know, what happened right before the chest pain? What was the antecedent to you experiencing this symptom? You know, come to find out they had just gotten a phone call from their primary care office letting them know that there was an abnormal lab test. With someone who already has underlying anxiety, this, of course, is going to trigger even more anxiety, and it can sometimes create panic attacks. And so sometimes what the client is presenting in the ED isn't always exactly what it looks like. And so that just offers us a little bit more detail and look into what this person is dealing with when they are showing up to the ED. And are we addressing not only the presenting problem, but maybe the underlying problem underneath what they're coming to the ED for? And a lot of the time, based on, so that example with the client who had chest pain around the abnormal lab results, that gives us the insight around, oh, well, why don't we start accessing lab results, and let that client know, you know, if you're starting to feel anxious about this, give us a call. Let's see if we can look up those lab results in HealthInfoNet, and maybe they can meet with our nurse care manager to go over those lab results. So they're not sitting around waiting for 2 weeks to get into their primary care office to take a look at those lab results. Next slide. So the other thing we really like to do is explore the treatment that happened while they were in the emergency department or the hospital with the client. We like to have a sense of, does the client actually understand what happened while they were there? We have quite a few clients who present to the ED. They're there for sometimes a couple of hours, sometimes a couple of days, and they really have no clue what happened while they were there. Were they taken off meds? Were their meds changed? Were meds added on? They just kind of are so caught up in the moment that they're not quite sure what happened. And we really, really try to push our clients to be involved in their own treatment. So this is a good starting point for us to explore with the client, do you understand what happened while you were there? And we try to read the HealthInfoNet summary with the client so they can see what they're showing up as treatment efforts made during that stay, and then kind of compare that to their own experience while they were there. We also go over the discharge summary with the client. That's a huge, huge part of this debriefing protocol because, as we know, making sure that a solid discharge is in place really helps the client to be successful after discharge. Next slide. Part of looking at that discharge plan is really looking at if the plan was realistic or if there was a plan put in place that is maybe setting up that client for failure. As I'm sure everyone knows, a lot of the time what doctors or discharge planners think is realistic doesn't always align with the reality of our clients and their situation. We've had clients who were hospitalized and discharged with plans to, take medications 4 times a day. They've got 3 follow-up appointments in the next week. And this is a client with, severe anxiety, depression, they isolate. When you add substance abuse onto that, it really makes that discharge plan incredibly unrealistic. And that's not something that doctors are aware of or discharge planners are necessarily aware of. So we try as best we can to get the client involved and make that known as much as possible. Because I'm coming from the viewpoint that what makes a discharge plan realistic is as much client involvement as we can get. With that being said, we really try to check in with the client when we're going over this debriefing protocol, checking in with them around, were you involved in this discharge? Before you left the ED, did they talk to you about your responsibilities when you leave? And really getting a sense of their own involvement while they were at the hospital. Along with that, and when we're discussing that, we try to teach self-advocacy skills, reminding the client that it's okay to say that the discharge plan isn't realistic for them. It's okay to say, I can't do that. Can we come up with another plan? Because a lot of our clients don't necessarily think they can do that. And I think are often, when that is being said, they're often viewed as being non-compliant. So we really try to work with them in being able to let providers know their limitations in a way that's going to set them up for success, and teaching them skills around how to present those limitations without seeming, quote unquote, not compliant. And then, of course, we just check in around how long they were in the hospital. Usually we like to try to get in touch with the client or the hospital before their discharge, but if we can't, we try to just get that basic information for our own records. Next slide. Again, we really focus on discharge in this debriefing protocol. We've got 2 sections of the debriefing protocol. One is focusing on discharge questions based on if the client has already discharged the hospital. If they have not discharged from the hospital, we have another section of that debriefing protocol that focuses on involvement with the client and planning the discharge from the hospital with the discharge planner. So as soon as we get in touch with the client and the facility that they're at, we kind of immediately go from reviewing what the presenting problem is, how they got there, treatment efforts, right into discharge. And we try to get that client as involved in the discharge process as possible. We really try to offer modeling for self-advocacy so that clients can see what it looks like to appropriately be involved in care without getting defensive or angry. Because I don't know if any of you guys have ever been in the emergency department, but it's pretty high stress. And again, when you have someone who's dealing with mental health issues and symptoms, it can be really hard to just advocate for yourself without becoming overly emotional. So we try to offer modeling in that sense as much as we can. If someone is still in the hospital, when we get in touch with them, we really try to be as involved with not only the providers in the hospital, but also the discharge planner while they're there. We want to make sure that kind of everything is set up and ready to go and that there's a good discharge plan before that person leaves. Next slide. So part of that is really kind of digging into what the barriers to a successful discharge might be. Are they having any medication changes? How are they going to get their medications when they get home? If it's someone who's going to need home health when they get home, have those referrals been made? Is the client going to engage with those services? How might this person get home? Transportation, we have found, has been a huge barrier, not only to getting someone home from the hospital, but also a barrier to getting someone to access the appropriate services. So we're seeing a lot of people presenting to the ED simply because they don't have good transportation to their primary care office or urgent care. So that's something that is really pretty constantly being discussed, and we're working on coming up with barriers around the issue of transportation. Again, we're going over the discharge plan with the client as much as possible. We want to make sure that that client is completely aware of the discharge plan, their involvement in the discharge plan, who's going to be involved once they get home. And we really try to get them to speak up as much as possible around, is this something you feel like you are going to be able to follow through with? You know, do you have any concerns or fears around going home or being able to follow up with any of this stuff? And then, you know, just do you have a basic understanding of this discharge? You know, we have a lot of people who don't read very well, don't completely understand medications and when they're to be taken. So just giving them, you know, a list of medications and when to take them isn't necessarily going to be a successful way to interact with a client. So we really try to just dig in as deep as possible with the client around what needs to happen to kind of prevent readmission. Next slide, please. The other piece that we try to accomplish either before discharge or right after is really getting the client in with an appointment with their primary care within 7 days, ideally. If we can't get them in with their primary care office, we try to schedule an appointment with our nurse care manager. Part of this is to really go over any kind of medication changes that have happened. We want to make sure that the client has the meds they need, they understand what meds they're supposed to be taken. The other thing we do is discuss, you know, once you're home and you start experiencing maybe certain symptoms, what do you do when that happens? So if we have someone who, let's say, was hospitalized with a UTI and they go home, we want to make sure that they know what to do if, let's say, they see blood in their urine or burning when they urinate. Sometimes going to the ED right away is not the best case scenario. Sometimes there are other providers that they can reach out to prior to presenting to the ED. And our nurse care manager really can focus on that if the primary care is not available. The last piece of the debriefing protocol is a 1-month follow-up after someone has presented to the ED. This really works best with clients who have had longer hospital stays, someone who has either been at Spring Harbor for a long period of time or, let's say, went to a skilled nursing facility for a while. We do this because a lot of the time when people come out of the hospital, that first month is that delicate month where things are going to start to fall through the cracks. You know, home health providers didn't show up, or the client didn't engage with those home health providers, or medications run out. I think it's hard for people when they've been in the hospital for a while to transition back home. So we really, again, focus on that discharge, get them set up for about a month or two after the discharge, and then we follow up and check in around how are you doing? Did you finish up with your home health providers? Do you need medication refills? How, do you need to get in with your PCP again? So yeah, that's kind of our main focus at the kind of end of that 1-month follow-up.
Well, thank you. Thank you so much, Abby, for sharing with us in such detail this very specific use of HealthInfoNet. You've built a tool that brings so much information and really does help to ensure a successful outpatient outcome for somebody after they've left either the inpatient or the ED hospital admission. So thank you so much. I want to now move on to our second speaker from Catholic Charities, Caroline Schnell. Caroline has a very, very interesting story to tell us. She uses HealthInfoNet in a way that I haven't heard that anyone else uses it. It's kind of a unique skill set that I hope we can all be inspired by her to apply ourselves. In a previous webinar, we did have one of our nurses kind of lament the fact that doctors and other providers were not looking at past lab histories. Well, Caroline does the same thing. She goes in and she looks at past ED admission notes. She's looking at the histories, and it leads to some interesting results. So, Caroline, there's one great story I did want you to, I know we're running a little short on time here, but
sure.
We do have time for your great story, and then we'll have time for Katie to speak at the end. But can you share with us this great story of how you use your analytical mind to kind of do your own analytical investigations within HealthInfoNet? So why don't you tell us the story that you told me?
Okay, just making sure you can hear me.
Can do.
Okay. I'm working with a client who I discovered was going into the ED for non-emergency reasons. For example, like for foot pain or fatigue or just not feeling well. What was helpful about HealthInfoNet is that I was able to go into her chart and see these multiple ED admissions notes and read through them, and it was through that I realized, she was going to the emergency department for, these non-urgent needs. And so one day she came into the office and she was saying, I'm not feeling well, I'm sort of feverish, I'm having a lot of leg pain. And I knew from sort of doing this research in her chart that those were some of the things that she talked about before she went to the emergency department. And so we were able to then call her primary care doctor together. In fact, I think I had asked her, I said, have you thought about going to your doctor first? And she said, yeah, but I couldn't reach them on the phone. And I knew that she was, again, someone that was likely to just walk up the street to the ED. And so I said, why don't we just go upstairs and sit down together and we can make the call to your doctor right now. And so we were able to schedule her an appointment, within 2 hours. I think that if I had not known that she went to the ED for the symptoms that she mentioned, then it wouldn't have alerted me to sort of be more proactive about getting her scheduled with her primary care provider. just because, the symptoms aren't typical reasons that you would go to the ED for. So that's really the biggest way that I've used HealthInfoNet, is kind of being able to look at the trends of some of our clients and know what they're likely to complain about or say prior to an ED admission.
And that's really important, that you do that, Caroline, because you're able to, that would not be a typical reason to go to the ED, as you've mentioned, but you know that it's typical for this person, and everything is so individual, and you go in and you look at those histories, and that's what you dig up. I mean, I've never heard of anybody else doing that, so I want to call out you on that, so that's why I really wanted to have you on today to share that story. Thank you for joining us and inspiring us with that, and to Abby for building on top of HealthInfoNet such a brilliant discharge protocol instrument, and we will be sharing that with everyone in the next couple of days. And now I'm going to hand this over to our program director, Katie Sensei, who has some important information to go over with us. So, Katie, I'll hand it over to you. Katie, if you're on, I can't hear you. It's *7 to unmute yourself.
How's this?
I can hear you, yes.
Okay, wonderful. Well, good afternoon, everybody. I just have a few short slides, so hang in there with me. I wanted to present the plan around when the SIM grant is technically ending. So I'm going to go through a couple key timelines and some decisions that have been made, and then there's some decisions that still have not been made. And then I'll take any questions or we can follow up one-to-one on email if you have specific questions about your contract. As far as the contract that everybody signed at the beginning of the cycle, I know there's a couple of people that have a different timeline. The standard timeline terminates at the end of September. And we did that on purpose because the grant was subsidizing the work, and we have all of the milestones that we're paying out as we complete the work. So what we're planning for is to push out a clean new version of a bidirectional data sharing contract with HealthInfoNet that would have a starting date of October 1st. And in our standard contract template, it's what we call an evergreen contract, and that means that it has an auto-renew clause unless you otherwise decide not to continue with the service. It has all of the typical discontinuation clauses that you would typically find. But what's good about the auto-renew clause is that we don't have to keep redoing these contracts again and again and again. So the idea is to move you on to a new contract and then have that be done so that we don't have to keep revisiting that. Next slide, Jenna. So budget planning, I know since the beginning of this grant, people have been thinking about, well, what happens after SIM? What is the fee structure like to continue? And so I want to review with you the decisions HealthInfoNet has made after analyzing some of the data you all have provided to us. We've been doing different cost analysis across all of our services and with all of our clients, and we can get into different details based on folks' questions. But the key message that I wanted to share today was that you all have been subsidized to do the, quote, initial connection of data sharing. And so typically when we have a client, we have initial one-time connection fees to get the IT systems connected. So that's been subsidized, and you've had received payment for those milestones. So going forward, it will be the annual, what we call our annual subscription fee. And what we've decided to do is to take a new approach with the behavioral health contracts because of the nature of the work that you do and the nature of the staff that you employ, and move towards more of a population management structure with the contract. So we're trying to adjust the way we charge services, just like the rest of healthcare reform activities is trying to move to a more holistic approach. So what we've decided to do is here on the slide to charge an annual per client per year fee. And it's really important that we establish what your estimated client base is on an annual basis so that we're not duplicating clients across clients that may receive services in multiple programs. And then there's always special situations as well, like going into schools, things like that. So it's not, it's detailed. And so what we want to do is have a conversation with each point of contact for the contract, arrive at your annual estimate for clients served, agree upon that, make sure everyone's questions are answered around what to include, what not to include, things like that, and then we will then send you the revised contract based on those conversations. So you're not just going to get a contract that's a big surprise. We'll have talked to you about it. We'll have arrived at the client population estimate, and that will be what we included. So, Gemma, you can go on to the next slide because we're going to talk about that. So, yeah, I mean, basically this is an example of what I just said. I think it's pretty self-explanatory. But go ahead, Gemma. So next step, we'll be working hard as the summer comes to an end to get some contract conversations in place and get the contract out to you in a timely manner. And typically when we invoice at the time of the contract being completed. But I know that every organization has a slightly different annual budget cycle. And so if there's any concerns related to that and that you want to stay on, you want a contract, but it's a payment issue, then we can work with you on that. And so I just want to put that out there. I don't want anyone to be stressed out and nervous about this and not speak up and say that you have a unique situation. So we'll work with you on these things and discuss any concerns that you might have. And then I think the last slide, I want to talk about those organizations that are potentially at risk for not completing the final milestone of the SIM grant. And there's a couple. The vast majority of you are either already live with sharing data and are simply completing the quality project. So you're in a great place to finish all of your milestones on time and receive full payment through the SIM grant. However, there's a couple of folks that may not meet the September 30th deadline. And so what I want to share with you, if you don't already know, is that DHHS has received approval for a no-cost extension of the SIM grant. And the majority of that work is going to be related to their evaluation that they're doing and working on those kinds of things. However, there is some potential room to continue to work with people that haven't gone live with data sharing after September 30th. So we don't have a final plan for what that looks like yet, and we don't have final approval yet, but this is what we're talking about with SIM leadership right now. So our goal is that, let's say that there's two organizations that haven't completed the final data sharing milestones because of vendor delays that have had, you have had no role in that. It's really you're dependent on your vendor. Our goal would be to do the same thing, re-sign a new contract, estimate your clients served, and include that in the annual contract for a subscription fee. However, we would likewise continue to work with you on paying you the remainder of the milestones that you have not yet been able to achieve, so that you reap the same rewards that everyone else did under the SIM grant. And really that's because it doesn't help anyone if you don't meet these goals. I mean, we're all working in this together in good faith, and everyone's been working very hard and making the best effort possible. And unexpected and unplanned things happen. They're outside of our control. So everyone's trying to work together collaboratively to make that happen so we can continue with getting the remainder connections that we are anticipating maybe would not be ready for September. So I think that's it, Gemma. And I'm happy to take any questions now, or folks know where to find Gemma and I.
Thank you, Katie. If anybody has any questions, you can put those into chat now. you can also do a *7 to unmute yourself and speak up if you'd prefer to do that. Others of you may just prefer to think about these things and send in questions to us as you think about it and mull this over, and that's fine too. I'm not seeing anything coming into chat, and nobody is calling in. I'm just going to give you a few more seconds to do that in case you're quiet, but I'm not seeing it. I think people are anxious to get back to work, and I understand that. So I'm just going to then remind everyone to join us for our next webinar. Before we close, I do want to thank our speakers today. Jason, Abby, Caroline, Ariana, you were all so wonderful to share your time and your stories today. All of you on the call, you are all doing such great work. Every organization is doing great work with HealthInfoNet, and HealthInfoNet is a tool, as I mentioned earlier, that as great as it is, it's not great unless the users use it in a creative way that makes it great, and that's what you do. So thank you so much, and don't forget to get in touch with me with any questions or if you have any concerns. Thanks, everyone. Have a great day.